In the previous video, we have discussed about the definition of shock and pathophysiology of shock. So this is the continuation of the video, the classification of shock. I hope if you didn't see the previous video, I'd like to ask you to see this video. This is very important video. So here comes the classification of shock. Shock is mainly classified into 4 types. This is obstructive shock, cardiogenic shock, distributive shock and hypovolemic shock, as well as the endocrine shock. Do we need to know about the classification? Why do you think classification is important? So to know the cause, the exact cause of the disease. The cause, if we treat the cause, we'll treat the disease. So to know about the cause, we have classified the shock. First type of shock is hemorrhagic shock or hypovolemic shock. It is the most common type of shock seen in case of surgery. As the name indicates, the hemorrhagic shock means due to hemorrhage, or that is if there is any RTA or any major accident or major surgery due to any loss of blood, this is the hemorrhagic shock. Hypovolemic shock includes the fluid or volume. So this is nothing but due to decrease in the fluid or volume in the hemorrhagic cause and non-hemorrhagic causes. This is classified as 2 types. In case of hemorrhagic cause, as we have discussed, it may be major RTAs or any trauma or any surgeries. All these are included in the hemorrhagic causes. The non-hemorrhagic causes include if there is a patient, suppose this is the patient, there is the decreased intake and increased loss. That's it. This is classified as 2 types. Decrease in fluid intake, this will cause severe dehydration, and in case of increase in fluid loss, it might be due to increase in fluid loss, it may be due to vomitings, diarrhea, urinary loss and third space loss. This is a new terminology which you might have heard. This is very important in case of surgeries, in case of any intestinal obstruction, or in case of any perforation. If the patient is sick, it is most commonly due to third space loss. You will see the hypovolemic shock in this patient. This is very important to resuscitate this patient. Early intervention can bring them back alive. So this is very important, third space loss. This is about the hypovolemic or hemorrhagic shock. Let's move on to next type of shock, that is cardiogenic shock. The name itself is indicating cardiogenic shock at the level of heart. So this heart has failed. So heart will think, so okay, today we'll stop pumping the blood. So this is primary failure of heart to pump blood to the tissue. This is cardiogenic shock. Always try to remember the causes instead of mugging them up. If you try to think in a logical way, you will remember it more number of days. So cardiogenic shock, the heart can't pump. What is the most common condition which you know in the heart? So which you hear every here and now? That is myocardial infarction and rhythm disturbances causing cardiac dysrhythmias, and heart has some valves. So there will be valvular heart disease or any trauma to the heart or any cardiac myopathy. All these will contribute to the cardiogenic shock. There is something called, in case of venous hypertension with pulmonary or systemic edema, there are always signs of shock. This is very important. Next comes our obstructive shock. The name itself signifies that there is some kind of obstruction. For example, if there is an obstruction to the blood, over here you have kept a big boulder or big thrombus. Can the blood pass freely beyond the obstruction? No. So this is the obstruction. Here mechanical obstruction to cardiac will be present in case of obstructive shock. Same likewise, how do you remember the causes of the obstructive shock? Something is obstructing. Suppose in the mediastinum, what are the organs? You know, in the mediastinum there will be heart, there will be lungs, and there will be major blood vessels. This heart has something called pericardium, the layer around the heart, pericardium. If there is fluid around the pericardium, asking it not to expand, don't expand, you have to shut down like that. So there is something external pressure over the heart, that is cardiac tamponade. This condition is known as cardiac tamponade. There is something called pneumothorax. When there is collapse of the lung, there will be external compression over the heart by the lung. So there is tension pneumothorax, and there is massive pulmonary embolism or air embolism. All these are the causes of obstructive shock. What will happen? So why should we know what will happen? Okay, it will happen. So what should we do? This is the decreased filling of left or right side of heart. This will cause decrease in preload, and there is decrease in cardiac output. So if it is cardiac tamponade, we have to relieve it by pericardiocentesis, all this. So if you know the cause, it will guide you to the treatment. In case of tension pneumothorax, if you place prompt intercostal drainage tube placement, there is decrease in compression of heart from the lungs. So all these, so these are the ways which you have to think how will we apply clinically of this case. Okay, next comes our distributive shock. The next type, this is nothing but how does a heart, that is cardiovascular system, will respond to different types of conditions. Here there will be vasodilation, very important. In all kinds of shock there will be vasoconstriction, but in case of distributive shock there will be vasodilation. The main causes include septic shock, anaphylactic shock and spinal cord injury, but the vasodilation, cause of vasodilation is different in different conditions. For example, in septic shock, how does sepsis occur? Due to your bacteria. Due to the bacteria releasing the endotoxins into the bloodstream. This will cause maldistribution of blood flow at the microvascular level, leading to AV shunting as well as decrease in O2 utilization by the cell. This causes the vasodilation. So this is the cause of vasodilation in case of septic shock. Whereas in case of anaphylaxis, due to any allergic reactions or anything, there will be release of histamine. This will cause the vasodilation in case of anaphylaxis. In case of spinal cord injury, there will be a failure of the sympathetic outflow and loss of vascular toe. As we have described earlier, increase in sympathetic activity will cause increase in heart rate and vasoconstriction. So when there is blockage of the sympathetic outflow, there will be vasodilation as well as the loss of vascular tone. So blood vessel has to have a tone not to maintain the flow. So when there is decrease in tone or loss of tone, it will stop contracting and it will relax. This will cause vasodilation. So have you understood why am I telling all this? So in case of vasodilation in septic shock, it is due to this AV shunting at the cellular level. In anaphylaxis, it is histamine release. So we have to give treatment accordingly. Next comes our endocrine shock. This is a special type of shock where you see always a combination of different types of shocks. Whenever I tell the word endocrine, what are the organs which you remember? Like I personally remember thyroid whenever you say endocrine. So here I am talking about thyroid. In case of hypothyroid and hyperthyroidism, what will happen? In hypothyroidism, there will be decrease in heart rate and decrease in the inotropy of the heart, leading to decrease in cardiac output. This hypothyroidism will cause low cardiac output failure, and in case of hyperthyroidism there will be high output cardiac failure. And next comes our organ which rests on our kidneys, that is adrenal gland. This adrenal insufficiency will cause hypovolemia, and there will be very important thing, poor response to the circulating and exogenous catecholamines. This will cause adrenal insufficiency. So these are all the types of endocrine shock. This is a beautiful tabular form given in our Bailey to summarize the whole topic. So in cardiac output will be, in case of hypovolemic shock, as there is decrease in preload and decrease in afterload, cardiac output will be low. In case of cardiogenic, heart itself will fail to pump, there will be decreased output. In case of obstruction, the area around the heart will try to block the flow, there will be decreased cardiac output. But in case of distributive, it is always high. So exception is your distributive shock. Systemic vascular resistance is high in all the cases except the distributive shock. And venous pressure will be high in case of cardiogenic and obstructive shock. Okay, next comes our clinical consequences of shock. How does the body will cope up with all this? This is the unresistable shock. So body will say, no, I can't do work today. Body will feel tired after doing so many things to compensate the shock. Ability of the body to compensate is lost. At the level of heart, it will show some action, and at the level of peripheral, it will show some action. At the level of heart, there will be a myocardial cell death. Why? In case of shock, as we have discussed earlier, there will be decreased O2 and decrease in the tissue perfusion, leading to myocardial cell death, will cause poor coronary perfusion. And in case of acidosis due to hyperkalemia, there will be a myocardial depression. What will happen in depression? Patient won't work. So if you are in depression, can you do work? No, right? In the same way, when the heart is in depression, it can't pump out the blood. So there will be decrease in cardiac output and limited response to fluid. It will say, I won't eat, I won't drink, I don't want anything. You will say no in depression. So I don't want anything. In the same way, there will be limited response to fluids or any inotropic therapy. And in the peripheral system, there will be loss of systemic vascular resistance, leading to vasodilation of the blood vessels. This vasodilation will cause decrease in the blood pressure, hypotension. So this will not respond to vasopressors in case of unresistable shock. Okay. There is something called ischemia, reperfusion and systemic inflammatory response syndrome. This is the same thing which I have been telling since the beginning of this video. When there is hypoxia, there will be cellular damage. In the metabolic response to injury, I have given detailed description about the dams and how does the body react to any kind of injury or any trauma or any surgery. If you have any doubts, kindly go through that video. Here hypoxia will cause cell damage. This will release damage associated molecular proteins. So the leukocytes are activated and cellular and humoral elements are activated. If these are released into the systemic circulation, this will cause organ injury. Main organs include acute kidney injury, lung injury and cerebral edema, leading to multi-organ dysfunction syndrome as well as death. So this is another tabular form given in Bailey. These are the effects of organ failure. In case of heart, it will cause heart failure. In lung, acute respiratory distress syndrome. In case of kidney, aka acute kidney injury or acute renal insufficiency. In case of liver, they will cause liver failure as well as coagulopathy. In case of brain, there will be cerebral edema. How do we recognize and how do we diagnose it? Shock, you are telling shock, everything okay, fine. So how should we know? How do we know that it is shock? It could be a normal condition of the patient also. Why should we think in terms of shock? So let's see. There is something called compensated shock. So if the patient is came to ER with normal blood pressure, okay, normal blood pressure, is it considered shock? No ma'am, you will tell so blood pressure is normal, so it is not shock. No, there can be normal blood pressure in despite of shock. How? Let me tell you. Adequate cardiovascular compensation will cause the blood volume and reserves the flow to the vital organs. They will cause tachycardia and cool peripheries, as the blood will be diverted from skin, muscle and GIT into the vital organs. There will be anaerobic respiration present over the skin, muscle and gut. Anaerobic respiration will cause systemic metabolic acidosis despite of normal urine output and cardiovascular vital signs. This is very important. In case of early shock, you can see normal BP despite of shock, but if this goes on for more than 12 hours, then you will see the increase in mortality, increase in infection rate and increase in incidence of multi-organ dysfunction syndrome. Okay, when does the body decompensate? So body will compensate. Okay, body will tell, okay Baba, only up to 15% I will compensate, more than that I can't. So up to 15% of volume loss body can compensate. This is important. This percentage of loss is also important. Beyond 15%, that is 30 to 40%, the BP will fall. This is the last thing to fall. You always think that BP falls first. No, even in spite of normal BP, there can be shock. These are the clinical features of shock in case of compensated and uncompensated shock. That is mild, moderate and severe. In case of mild, there will be lactic acidosis, see, which we have been discussing till now. Urine output can be normal even in spite of shock. But in case of moderate, the output will be reduced. In case of severe, there will be zero output. In consciousness, mild anxiety will be present. Patient will be drowsy in case of moderate shock and comatose or unconscious in case of severe shock. In respiratory rate, so due to anxiety, how does a patient with anxiety look? With increased respiration. So there will be increased respiratory rate in case of mild, moderate. But in case of uncompensated, patient will be in labored respiration. In case of pulse rate, tachycardia will be there as the body will try to compensate. In case of blood pressure, there can be normal. Blood pressure can be normal, and in initial phases there will be normal urine output. Mild hypotension, severe hypotension, this is the last thing to occur. So don't assume if BP is low only then we'll consider it as shock. No, if BP can be low, blood pressure can be normal in case of shock. So the main another clinical feature is capillary refill time, that is which is prolonged in case of hypovolemic shock and decreases in case of septic shock. But this is not a specific marker. As we have discussed, pulse rate is increased. Where exceptions are, where do we not see tachycardia, that is patients using beta blockers and patients with cardiac pacemakers, there is no tachycardia. In case of blood pressure, hypotension is the last sign of shock. So this is the main important thing. So this is how briefly the classification of shock, as well as how do we diagnose a shock, how does a compensated and decompensated shock look like, what is unresistable shock, all these things I have tried to sum up in this video. If you like this video, please like, share and subscribe to my channel. And if you have any queries, I'd like to know in the comments, and I'd like to know how is the video, and do I need to make it more simplified to you. And if you have any queries, kindly comment. Thank you. Please subscribe to my channel.